Picture this. Your provider scrolling down a list of lab results, sodium, potassium, BUN, creatinine, and then you get to GFR. You see there's one specifically for Black patients and one for everybody else. Why? First, let's talk about what GFR is. GFR, or glomerular filtration rate, is the gold standard measurement for kidney health. A higher value means better kidney health, and a lower value means worse kidney health. We never actually know a patient's true GFR, but measured GFR, or mGFR, is about as accurate as we can get. To get mGFR, a marker such as iohexol or iothalamate is given to the patient by IV in one large dose. As the marker gets filtered by the kidneys, levels decrease in the blood and increase in the urine over time. These changes are monitored and used to calculate mGFR. Although this method is very accurate, it's really time-consuming, intensive, and not very practical for routine care. So we came up with estimated GFR, or eGFR. eGFR is calculated by one blood sample measuring levels of a specific marker, such as creatinine, which is a waste product of muscle cells, or cystatin C, which is found in all cells with a nucleus. The marker level is used in an equation to calculate eGFR based on the patient's age, sex, and sometimes race and weight. Commonly used equations include the CKD-epi-creatinine and the MD-RD equations, which use race, and the CKD-epi-cystatin C and the Mayo Clinic quadratic equations, which don't use race. So why is race used in some of these equations? A study in 1999 and another in 2009 found that Black patients had higher mGFR values than non-Black patients with the same creatinine levels in the blood. Therefore, they concluded that eGFR needs to account for this racial difference. Possible explanations include differences in diet, differences in muscle mass, and differences in how the kidneys eliminate creatinine. But further research is being done by the National Kidney Foundation to further assess these claims. We need to have a serious discussion about race-based medicine. One reason medicine categorizes people by race is because it's thought that the races are genetically different. In history, populations settled in particular geographical areas, for example, Africa, Europe, Asia, and the Americas. Today, we classify the people of those geographical areas into races. Natural selection selected for certain genes more in some areas than others. This led to a difference in their genotypes and ultimately their traits. For example, this is why Africans historically have had higher rates for the genes for sickle cell disease. In the context of GFR, it's thought that Black patients may have genes that lead to differences in muscle mass and how the kidneys eliminate creatinine. There's a lot of issues with this claim. The first issue is how we define race. Hunt and Meghesi conducted interviews with 30 geneticists in the US and Canada and found that definitions of race were often unclear, inconsistent, and context-specific. For example, according to the 2020 US Census, Arabs and Iranians are both considered white, despite both groups experiencing discrimination as POCs, or people of color. Also, patients are often asked to self-identify their race, which makes it subjective and confusing, especially in the case of mixed-raced individuals. The second issue is, according to the American Society of Human Genetics, due to migration and mixing of different populations throughout history, there's considerable genetic overlap between populations, and genetic variation is more of a gradient, without distinct racial boundaries. In other words, races are not as genetically distinct as we thought. Race is just a social construct. The third issue is making clinical decisions based on social constructs like race. Calculations based on race adjustment give all Black patients higher eGFR values, including Black patients who may not even have the supposed genes that affect muscle mass or how the kidneys eliminate creatinine. This may result in a Black patient being bumped up to a milder kidney disease stage and possibly being excluded from certain interventions that they might actually need, such as a nephrologist referral, hemodialysis, or even a kidney transplant, all of which are given to patients based on their kidney disease stage, which is calculated by their GFR. So where do we go from here? Sardinia, Plasime, and Tsai in 2020 make the case for moving from race-based medicine to race-conscious medicine. This can be summarized in 3 steps. Step 1. Avoid racially tailored practices that propagate inequity. Race is different from genetic ancestry. Therefore, we should not make inferences about a patient's physiology based on their race. Race-adjusted scales should be abandoned or replaced. Step 2. Teach healthcare students how health disparities can be caused by structural racism. When we say Black people are at higher risk for hypertension, we should consider how race overlaps with structural barriers to health, like socioeconomic status, discrimination, transportation, environmental exposures, criminal history, documentation status, English proficiency, and neighborhood violence. Step 3. Clinical leadership should denounce race-based medicine. Medical students are taught that race is relevant to treatment decisions, and they have inadequate power to question the racialized assumptions of their supervisors. Here's a figure I want to share from their study, comparing race-based medicine to race-conscious medicine. Lastly, I want to leave you with some words from nephrologist Dr. Grubb's recent paper, Precision in GFR Reporting. Going forward, we must question our decisions to center biologic science around constructs that, instead of having a biologic basis beyond superficial classifications around skin color and hair texture, are muddled with complicated and unmeasurable societal factors. Here are my references for the information used in this video.